Okay, we're going to talk about heart failure today, and I'm going to start off again with a little video. I like the way that this video explains things, and so I want you to go ahead and listen to the video and take notes from it.
The topic of today's talk is going to be pathophysiology of heart failure. And now this is quite the extensive topic, but I think I can break this down for you into an algorithm that allows you to see how any cardiac complication or cardiac problem can lead to heart failure through one of various mechanisms that we're going to describe. What we're going to do first is go over some very important variables and equations in cardiac physiology, and then show you how things go wrong with those equations in order to lead to heart failure. So the first thing that we need to talk about is cardiac output. And cardiac output equals heart rate times stroke volume. Now, if you're lost already, that's okay. We're going to define these for you in really simple terms. So heart rate is the amount of times that your heart beats per minute. And stroke volume is the amount of blood in milliliters that your heart pumps out per beat. And so when you do the math, these cancel out, and the units for cardiac output are milliliters per minute. And so cardiac output is how much blood your heart pumps out in milliliters per minute. Now, what we have to do is see what determines how fast your heart beats and how much blood your heart pumps out with each beat. Okay, so we're going to rewrite the equation up here. Cardiac output equals heart rate times stroke volume. And we're going to talk about what goes into each of these variables. Heart rate is pretty easy. In the right atrium of the heart, there's a specialized group of cells known as sinoatrial nodal cells. And so you have a node up here known as the sinoatrial node or the sinus node, and that determines how fast your heart's going to beat. Now there is autonomic input from the sympathetic system, which will increase the heart rate, and also from the parasympathetic system, which will decrease the heart rate. So these will modulate the sinoatrial node and allow for the heart to beat either faster or slower. Now, stroke volume is not quite as straightforward and is actually composed of three different things that determine how much blood you're going to pump out with each beat. And so the first one we're going to talk about is afterload. And I'm going to define these terms in a second. The second one is contractility. And the final one is known as preload. And you'll also see this as EDV, or end diastolic volume. So let's go over what each of these mean. And it's important to note that before we begin explaining these terms can apply to both the right and left side. But more commonly, when people use these terms, they're talking about the left side because this is the side that generates your arterial pressure. So afterload is the pressure that the left ventricle right here has to pump out against. And so that's this pressure here in the aorta that is basically opposing the blood coming from the left ventricle. So the pressure in this chamber is going to have to actually exceed that here in order to eject blood properly. Now, contractility is the actual vigor or force that this left ventricle contracts with. And this measurement, contractility, is independent of both the afterload and the preload. And so finally, the last variable is called preload. And preload is really just how much blood is coming in and filling the ventricle before it gets pumped out. And the reason you see EDV, which stands for end diastolic volume, and so at the end of diastole, when all the blood has come from the left atrium and into the left ventricle to fill it before it ejects, this is preload, or the volume at the end of diastole in the left ventricle. So I hope that those terms are clear, and now let's move on to how these three, afterload, contractility, and preload or end diastolic volume contribute to stroke volume and overall to cardiac output. And so you'll see what I've done here is just list the three variables that we were talking about. And what I'm going to do here is make a little line separating preload from contractility and afterload. And we'll see why I do that in a second, but it's because they cause different types of heart failure. So what happens when things go wrong? In the case of increased afterload, exactly what you think would happen. The stroke volume would go down. You're pumping against a higher pressure. You can't pump out as much. With contractility, if you have a decrease in the vigor or force of the heart muscle and it's pumping, you get a decrease in stroke volume. And finally, if you have a decrease in preload or end diastolic volume, you get a decrease in stroke volume. If you're putting less in, you get less out. And so these seem pretty simple, but really most, if not all, of the diseases of the heart can actually be traced back to modulating one of these factors. So we're going to talk about three diseases that can actually do these things, just to give you a little bit of a clinical context for how these diseases would affect afterload, contractility, and preload. So a disease of increased afterload would be something like chronic hypertension. And this chronic hypertension means that you have an extremely high pressure against which the heart has to contract. And like we said, that's going to lead to a decreased stroke volume. Now, a decrease in contractility could occur with something such as coronary artery disease or chronic ischemia. Ischemia just means lack of blood flow. And so if you have coronary artery disease, the heart is not getting as much oxygen and blood that it needs, and it can't contract as vigorously, and thus you get a decreased stroke volume. Finally, a disease in which you would have a decreased preload is a little less common than the other two that we mentioned, but something like constrictive pericarditis. And so the pericardium is the sac that surrounds the heart, and in cases like infection or something like a heart attack, you can get chronic inflammation of that sac that surrounds the heart. And what happens is it becomes very fibrotic and scarred and doesn't allow the heart to expand. And so if the heart can't expand to take in the volume that fills it, you get a decreased preload or a decreased end diastolic volume and a decreased stroke volume. So now you can see how some common conditions that we see in the hospital every day can actually lead to heart failure. And so the last term that I want to introduce to you is something called ejection fraction. And the ejection fraction is no more than the stroke volume over the end diastolic volume. And in layman's terms, that just means how much blood are you pumping out in relation to how much you got in. And so a normal ejection fraction is something like 55%. And ejection fraction is also commonly used in the clinic to evaluate heart function. And the reason I introduce this is because we can look and see what happens to the ejection fraction when all three of these variables are changed. And so if the stroke volume decreases in both increased afterload or decreased contractility, the preload or end diastolic volume is either going to not change or will actually increase, because since you're not pumping as much blood out with each beat because you have a decreased stroke volume, some of that blood is retained and this value may actually go up. But what the point is that ejection fraction, because stroke volume is going down and end diastolic volume is going up, ejection fraction is reduced. And another name for reduced ejection fraction heart failure is systolic heart failure. And both a decrease in contractility and or an increase in afterload can cause systolic heart failure. Now, if we go over to the preload side, the ejection fraction here will be different. And so you have a decreased stroke volume, but you also have a decreased preload or end diastolic volume. And so if both of those decrease the same amount, you actually have no change in ejection fraction. And this is called preserved ejection fraction heart failure, or diastolic heart failure. So I hope that by watching this, even though there are a lot of variables and a lot of equations.
Okay, so I think that gave you a very good explanation of what is going on in heart failure, and I covered everything that I would have on the next couple slides. Um, a little bit about compensatory mechanisms. Your book goes into a whole lot of stuff, but what I want you to understand, and it kind of talked about it in here a little bit, um, the body is going to try to compensate for all these problems of heart failure that you're going to see, and these are the ones that I want you to know for the test. I'm not going to ask you all the stuff in the book, but you need to understand that the heart will try to compensate by increasing the preload, which means to increase the amount of blood that's coming in. It's going to try to increase contractility. The body, it does this by the muscle hypertrophying to pump harder. So the left ventricle becomes a hypertrophy. And we also will have an activation of that sympathetic nervous system, which is your fight or flight response, if you remember all of that. So the next slide, I'm going to do another short video.
So your heart pumps blood essentially to two places. In the first place is your body. So you have your oxygenated blood on the left side, and we gotta remember that the lefts and the rights are switched because we're looking at the anatomical view of the heart. So it pumps it out to your body, and your body gets that oxygen. Your body uses it up and then circulates it back into the right side, where this time it's pumped out to the lungs and gets reoxygenated and gets that oxygen back, and then it's circulated back into the left side. And the amount of blood at any time pumped to your body is sort of based on this demand that your body has for blood. You can kind of think of it like you have this gauge that says, hey, I need this much blood to sustain this much activity. And this can change. So like if you start working out or something, your demands might go up. And your heart can accommodate for that and start pumping more blood to that body to meet those new demands. Heart failure describes this condition where the heart can't meet the demands of the body. So at any given time, the heart's not able to pump enough blood to meet the body's demands. And there are essentially two types of heart failure. The first one we call systolic heart failure. And systolic refers to systole, which is the phase of the cardiac cycle where blood is pumped out of the heart. And so systolic heart failure is when those heart muscles aren't pumping blood with enough force. So this often means that those muscles are weakened and smaller than with a healthy heart. And this typically makes it look quite a bit different. And when these smaller muscles contract, they don't squeeze as hard as they used to. And this causes less blood to be ejected with each contraction. Now I say contraction because the heart's this muscle, right? So when it contracts, it squeezes. You can kind of think of it like you have this water bottle that you're holding with your hand, and you squeeze the water bottle and it shoots the water out. It's the same concept with your heart. When those muscles contract, they squeeze the blood, and that's how you eject blood to both your body and your lungs. With systolic heart failure, since your heart muscles are smaller, think about squeezing that water bottle again, but just pinching it. It's going to be a lot harder to squeeze the water out, right? Well, it's the same thing for the heart with smaller and weaker muscles. It's going to be way harder for it to squeeze and pump that blood out to the body. You probably noticed this heart has these sort of enlarged looking lower chambers, and at the same time it has this really thin muscle wall. And these are really characteristic traits of a heart with systolic failure. And these small muscles make it really hard for it to pump blood to the body. So that was the first type of heart failure. The second type is called diastolic heart failure. And instead of being a pumping problem with the muscles being too small, diastolic failure is a filling problem, which is why we call it diastolic failure, because it refers to diastole, which is that phase in the cardiac cycle where the heart fills with blood. So with this type of failure, your body's not receiving enough blood because your heart's not filling with enough blood to pump out in the first place. So if we jump back to that water bottle analogy, this time you're holding it with one hand, just like we were for the healthy heart, but instead the bottle's filled with less water. So even if you squeeze it with the same force as a healthy heart, less water is going to be ejected simply because there's less water in the bottle. And this is essentially what's happening with diastolic failure. Since there's less blood filling in the ventricles, even if it's pumping with the same force, less blood's going to be ejected to the body. But why is there less blood filling in the chambers? Well, it's because those muscles are actually larger in this case, and they take up more space. and this leaves less space for that blood to fill into the ventricles. Okay, so far we've shown both types of heart failure, and each time we've shown it happening on both sides. Well, this isn't always the case. It's definitely possible to have isolated heart failure, so maybe you only have it on the left side. Or you might have it only isolated to the right side. One important thing to note, though, is that usually a left-sided case happens first, and then that ends up leading to a right-side failure. I know I'm only showing systolic failure here, but I should note that this isolated failure can happen with either systolic or diastolic. So depending on which side this is happening on, the left or the right, the symptoms are going to be a little different. Let's just go ahead and start with the left side first. So since the left side pumps blood out to the body, that means it's coming in from the lungs. And if it's not pumping it very efficiently to the body, that blood starts to get backed up into the lungs. Think of it like a traffic jam. What happens when they close a lane and then they only let one car through at a time? All those other cars get backed up. It's kind of the same thing. This blood gets backed up into the lungs because it's only pumping a little bit out at a time now. So a really common symptom of left-sided heart failure is fluid buildup in the lungs. This is called congestion, and it's also sometimes why we say congestive heart failure. Alright, so that was left-sided failure. Let's take a look at right-sided failure. Again, I'm just going to show systolic failure, but let's just note that this can happen with either systolic or diastolic. This time, since we know that the right side pumps blood to your lungs, we also know that it comes from the body. And since it doesn't pump blood as well to the lungs, we have that traffic jam situation again, but this time it gets backed up into the body. So patients with right-sided failure might start getting fluid buildup in their feet, legs, and abdomen. And again, just like the left side, you have congestion or fluid buildup, but this time it's in your body instead of your lungs. So as a quick recap, you could just have systolic failure on the right side, or you could just have systolic failure on the left side, and it's possible to have both. In the same way, you could have diastolic on the right side only, or you could have it only on the left side. Or you might have both. It's even possible to have a combination of systolic and diastolic failure. So now that we've kind of nailed those down, let's talk about this really important way that we measure the heart's ability to meet the demands of the body, and that's called cardiac output. Cardiac output represents the total amount of blood that the heart's able to pump every minute, usually given in liters of blood per minute. And a normal cardiac output is around 5 liters per minute. Now, cardiac output can be broken down into two other components. And the first is stroke volume, which is the amount of blood pumped out every beat, which is different than cardiac output because it's every beat, not every minute. And so we take this stroke volume and we multiply it by your heart rate, which is measured in beats per minute. And those two multiplied together equals your cardiac output. So if you were to change either stroke volume or heart rate, for example, let's say I lowered stroke volume, since cardiac output's dependent on these two variables, cardiac output's also going to go down. And that's what happens with heart failure. Cardiac output is lower because the heart's not pumping as much blood per minute. This is usually because there's a lowered stroke volume or a lowered amount of blood pumped out with each contraction. So usually heart failure is considered a secondary disease, meaning that it's caused by some kind of pre-existing or underlying disease that already affects cardiac output. Specifically, we're going to think about diseases that cause the death of cardiac muscle cells, which are also called cardiomyocytes. And when those muscle cells die, the heart gets weaker and it gets way worse at pumping blood. This lowers stroke volume, and then it also lowers your cardiac output. And when the cardiac output goes down, the heart has two options to increase it again, based on our equation, that's stroke volume and heart rate. And your heart actually does that, and this is called compensation. So your heart compensates by either squeezing harder and increasing stroke volume, or beating faster and increasing heart rate. In the early stages of heart failure, these methods can actually help quite a bit in compensating for a decreased supply. But over time, those surviving muscle cells become overworked because they're constantly trying to either beat faster or squeeze harder. But to do either of those things, those cells need more oxygen. And since this is the whole issue with heart failure in the first place, a decreased supply of oxygen, those muscle cells won't receive the oxygen and more muscle cells tend to die off. And when more die off, stroke volume goes down even more. And this causes that whole cycle to repeat, which causes heart failure to get worse and worse.
Okay. So that is the end of that video. And I think that gave you a very good understanding of heart failure and what the differences are and when we're going to see fluid in the lungs versus fluid in the extremities. Now, one thing that it didn't really cover is this lab that's called a BNP, brain natriuretic peptide. A normal level for a BNP is 0 to 100. And what we do is we draw this venous blood draw, and if the patient comes back greater than 100, then we can conclude that they have positive CHF exacerbation. So this is used to confirm the diagnosis. However, we don't use it alone because if a patient has, they could have other things going on too. So we do chest X-rays and echocardiograms and things like that. But BNP is something specific to heart failure, and so it is something that the body puts out in relation to when the heart is failing and not pumping adequately. And so I want you to relate the BNP to the heart failure, and if it's elevated, that does signify that they are in an exacerbation of heart failure. So I want you to consider these questions. I'm not going to answer them now, but I want you to think about these in terms of tests. If somebody had left-sided heart failure, what effect would it have on the peripheral blood flow, and why? Because we know that left-sided heart failure generally is going to back up and cause lung problems. But I need you to think about it the other way. If they have left-sided heart failure, what effect could it have on the peripheral blood flow, and why? If someone would develop, or why would someone develop paroxysmal nocturnal dyspnea, or sudden onset of shortness of breath at night when they have heart failure? I want you to consider these questions. Again, these are reference videos that you have access to, and I believe when you pull up your your PDF file, you can click on all of these references and it should bring you to the video. And that concludes the lecture on heart failure.